So we're going to move on to the next talk, which is, what are you laughing about? Common technical mistakes and how to avoid them. Lessons learned from the ACR CT Accreditation Program by Mike McNitt-Gray.
No pressure now, huh? Okay. I was going to say I'll probably be the only one to go over time today, but we'll see. I thought it was excellent from Bob Pizzatello, too. I really appreciate that. Okay, so let's talk about the ACR Accreditation Program, and I'm going to use this as a vehicle to talk about some of the mistakes that we've seen out there, and then I'm going to talk a little bit about dose, which is kind of what we're here for, right? So let's start with, first things first, with the ACR Accreditation Program. Those of you that have gone through it know that there's such a thing as Table 1. In Table 1, we describe, or someone is supposed to describe, the technical aspects to the site's protocols for adult head, high-risk chest, adult abdomen, and pediatric abdomen. And these are specific guidelines about what we mean by that for each of those protocols, including the pediatric abdomen is for assuming a 5-year-old patient. What Table 1 is really trying to tell us is what the site really does. That's supposed to be their clinical protocols. So when physicists or technologists or whoever's filling this out participates in this, they really need to understand and get participation from the site's lead radiologist, lead tech, understand that this is really the most important thing, no, maybe not the most important, it's a very important thing to fill out and to fill out correctly. And you may need, as a physicist, to assist them in filling it out. And I'm going to go through some of the things that are difficult when it comes to filling out Table 1. It seems pretty straightforward, but we've seen things that are not. Some common mistakes. There is a row in Table 1 that says, what is the MA for the adult head, or adult abdomen, or pediatric abdomen? Okay? But sometimes what people do is enter not MA, but MAS, or effective MAS, or MAS per slice, because that's what they see on their scanner. Okay? So we have to help the site understand the difference between these and the fact that they are not equivalent. I see submissions. I'm a reviewer. I've been part of the program since the beginning, and I see sites that say MA and in parentheses MAS, and sometimes that's right. And I see sometimes they put a value in there that's really effective MAS. So I'm going to walk through this for just a second and go through just a little bit of the details. I'm sorry if this is redundant for some of you, but I thought this would be important because Siemens uses a term called, when they do helical scans, they use a term called effective MAS. Okay? And what it really is the MA times the rotation time divided by pitch. You've heard that several times today, but I wanted to write it up there. To calculate the MA, you have to do a little algebra. Sorry about that. Okay, maybe when we go online, we'll build this into the spreadsheets or something. But you have to do a little algebra to calculate what that MA is, okay? And I'm going to show you why this is important in a second. It's not just a minor thing, okay? Philips uses something very similar called MAS per slice. It's the similar definition to effective MAS. And so, again, you have to do some algebra. Toshiba and GE scanners use MA time and pitch as independent things, so it's a little easier to fill out. Okay? So, what the mistake includes is they report the MAS, or effective MAS, or MAS per slice, and then, when they go to do a CTDI measurement, instead of doing because remember that effective MAS or MAS per slice is defined for a helical scan, and CTDI is defined for an axial scan, they'll do it at the wrong technique. Okay? So that means, for example, they use the MAS or effective MAS when performing CTDI. So, for example, here's a 200 effective MAS protocol, let's say, and it was a pitch of 0.9 and a rotation time of 0.5. And in this case, if you had gone through the algebra on the previous slide, you'd see the MA was 360. Okay? So they should perform a CTDI measurement with fixed table, okay, no table movement for right now, and 360 times 0.5 is 180 MAS, not the 200 that they reported in Table 1. The spreadsheet will correct for that using the fact that it used 180 and divide by the pitch of 0.9, and that'll correct for those values for effective MAS. Okay? So this can be a small thing, it can be a big thing. I'll show you why in just a second. If the site does this incorrectly, the spreadsheet will have incorrect values, right? If they had done the scan at 200 MAS instead of 180, then they'll have incorrect values. If they did it with 200 and they measured at 200, and then when they put in the number of channels, the width of each channel, and the table increment such that a pitch of 0.9 results, then the CTDI reported will actually be too high. It'll be higher than what the scanner reports, okay? Because they're taking that value and dividing by 0.9 essentially twice, okay? If the pitch is less than 1, the CTDI vol reported will be too high. And if the pitch is greater than 1, the CTDI vol reported will be too low. Okay? So it's really important for you to understand what the MA and effective MES, what those terms mean, what your scanner is using, and how to use them correctly in Table 1. And I use that really as a vehicle to say, look, it's confusing out there. Okay? And you really need to take some time, as Bob was suggesting, get to learn a scanner, get to understand the terms. They're in there. They're in those documents that nobody reads, but they're in there. Okay? Sorry. Okay. What about collimation? Also reported incorrectly sometimes. Okay? Again, this can be confusing for some scanners. For example, sorry to pick on Siemens, the Sensation 64, the interface says 64 by 0.6, or it says 0.6, or it implies a 64. But it really uses the Z flying focus spot, which double samples and gets 2 times the image. So you really get 64 images, but the actual beam width is 32 by 0.6. So that means the beam width is 19.2. So for a pitch of 1, the table travel is 19.2. I wish I could tell you how many times I've seen the table travel as 38.4. Okay? Because they multiplied 64 by 0.6, because that's what they thought. Okay? Again, this is our plea for transparency. This is our plea for people to dig into the documentation and to find out what this is. So does it matter? Well, if the site listed n equals 64 and t equals 0.6 and I equals 38.4, thinking that was a table, a pitch of 0.1, then actually that gives a CTDI vol of half of what it really should be. Okay? So again, it leads to a misunderstanding in terms of the dose. Okay. There are some others that I won't go into very much, but there's some reporting collimation incorrectly. There is an ACR website on the accreditation, on the ACR website for C-tier accreditation. There is a frequently asked questions page. Please take a look at that. And if it still doesn't answer your question, contact Teresa. There she is with her hand. Okay, and she'll farm it out to one of the physicists, or she'll answer it. Okay. Let's talk briefly about these things. Exceeding the dose limits, okay? These dose limits are out there. The guidances are all 5 milligray less than this. 75 for the head, 20 for peds abdomen, and 25 for adult abdomen. But what if a site exceeds these? Okay, it's a fail, and if you're the physicist, maybe you'll just let them fail. But I hope you won't. But what do you want to do? You want to have some conversation with them. Okay? Why are they doing that? Was the protocol followed and the scan done correctly when they did the CTDI measurement? Okay? Did they use the correct KVP and MAS as stated in Table 1? Okay? Or did they freelance? It's not uncommon for person A to fill out Table 1 and person B to do the actual measurements. And sometimes they don't match. And you said, well, I wish they looked at their own Table 1. Okay? If the answer to that is yes, they did exactly what they said in Table 1, and it's still greater than 80 milligray, are they trying to use the cerebrum technique or cerebellum? Or what is it that they're trying to do? Are they using too high a KVP? Can they get away with 120 KVP? And if they want to use 140 KVP, as some sites want to do for head, have they reduced the MAS? Okay? Have they compensated by going to a lower MAS there? Okay. Let's see. Some other things to think about. Is the MA or rotation time very high? You saw a great example. Now I can't remember who did it. You showed earlier when they went from a 4-slice to, or maybe it was a single slice to 4-slice, and they went from 170 MA in 2 seconds to 340 MA and 2 seconds. Whoops. I'm sure they didn't mean to do that. Okay? But it's not uncommon for this to happen. It's not common, but it's not uncommon. So is the MA or rotation time still too high? And we heard from Dr. Gupta some reasons why some sites do a helical scan and they use a low pitch value, right, to get away from some of the artifacts. If they're using a low pitch value, that's fine. Some manufacturers recommend that. But have they compensated by lowering their MAS? Again, if it's a Siemens scanner or a Philips scanner, that's built in. I haven't said this and I haven't heard anybody else say it, so I'm going to make it explicit now. In those scanners that use effective MAS or MAS per slice, as you change the pitch, the MA actually increases or decreases according to the pitch to keep that value, the effective MAS, constant. Okay? So, if the helical scan, if it's not one of those kind of scanners, and the helical scan and low pitch value is used, then sites should be aware they need to reduce their MAS. and we've talked about this a bunch of the morning, is the site using very thin slices? If so, they may see that increased noise, want to compensate, and increase the MAS. That may push them above 80 milligray. Okay. Peds abdomen, similar things. Are they using, let's see. Whoops. I've seen this where some sites lower the MA, but they also decrease the pitch. Whoops. That actually offset the reduction in MA. So it doesn't yield the intended net dose reduction. Some sites do lower the KVP and keep the MAS and pitch the same. That's cool. That can yield good dose savings, as we saw, just lowering the KVP. Okay? Most times you'll lower the KVP and increase the MAS to compensate. All right. Some other things before we get into some of the dose aspects. Low contrast resolution. This is probably one of the most common reasons I see for failing, is you can't see all 4 6-millimeter rods. It's a common reason for failure. Often sites are saying, well, I'm trying to reduce dose. Sometimes they may go too far. And this is why we have that low contrast limit. We don't want them to reduce the dose so that it's undiagnostic. Okay? So they reduce the technique, it increases the noise, and you can't see the 6-millimeter rod, kind of like this. Here's a scan that I did with 50 MAS. Okay? Can you see the 4-millimeter rods? You saw them from Jim earlier today. Can you see it? All right, here we go. Who said that? Who said they can see? I'm not going to tell you. Find them. I'm going to go up in MAS, and then I'm going to go back down. Ready? Here we go. 50, 100, 150. See it yet? 200. You see it yet? 250, 300. I hope you can see it now. Okay. 400. Okay, now I'm going to go, and there we go, 800. Don't do this, okay? It's just for illustration purposes. Okay, now I'm going to go back down. Here we go. Okay, so you couldn't see it at the very beginning. Now I'm going to work my way back down and see when you lose it. Okay, so 400, 300, 250, 200, 150, 150. Okay, so you lost it somewhere in there, right? Okay, so this is the kind of guidance that we can give to sites. They can use this, and it's good feedback to give them, but when they're hitting that limit where they've gone too low, okay, but sometimes they go too high as well. Okay, so low contrast is usually a barometer to see when they've gone too far in their dose reduction. Okay, I wanted to spend a few minutes talking about CTD-IVOL and DLP. Okay, what is it? What is it after all? Is that what we want to report? It's reported on the scanner. CTD-IVOL is currently reported on the scanner, and I had to make this point again. Sorry, it's not required in the United States. Okay, so occasionally you'll see it turned off. I'd be interested to hear from Bob or some other folks how often they see it displayed. And now I bet it's displayed a lot of places, but I bet a year ago it was turned off in some places. What is it? It's dosed to one of 2 phantoms, either 16 or 32 centimeter diameter. We had a little bit of dialogue earlier today about which phantom it is the dose to. It is not the dose to a specific patient. And it does not tell you, unfortunately, it does not tell you whether the scan was done correctly or a LARA or whatever term you want to put in there. That CTD-IVOL does not tell you that, right? I hope you appreciate that. It may be used as an index to patient dose with some additional information. I'll show you that later, okay? And now, what do I mean by that? Why did I say it doesn't tell you whether the scan was done correctly or not, okay? Because if you see a high value of CTD-IVOL, what does that tell you? It means the technique went up. It doesn't tell you why the technique went up. Was it a big patient? Did they use thin slices? Is that something they needed? Okay, it doesn't tell you that. Just the number by itself doesn't tell you that. Oops. Okay, so here's an example. Here's a small patient, here's a big patient. If they both got the same MAS, okay, same KVP, same MAS, same everything, guess what? The CTD-IVOL on that scanner reports the same number, right? Because it's dosed not to the patient, but to the phantom. Okay? It's dosed to the phantom. All right, now let's say a site does what we've been talking about all day today and adjusts the techniques for the patient. Okay? This one gets lower, this one gets higher. The CTD-IVOL is a factor of 2. I'm waiting for my big patient to come in and say, how come I got twice as much dose as skinny over there? Right? Did they? Did they get twice as much dose? No. No, they didn't. Okay? But the CTD-I reports that. And don't take this wrong. I'm not trying to badmouth CTD-I. Well, okay, I am. But I'm just trying to point out limitations. Okay. All right. All right, so we went through that. In scenario 1, CTDI is the same, but the smaller patient's dose is higher. CTDI is smaller for the smaller patient, but the patient dose is actually closer to equal in that second case. Now, I'm going to pitch some of my own stuff here in a second, if you don't mind. But CTDI vol, again, is not patient dose by itself. It can be misleading, and without other information, it really can be misleading. It really should be recorded with a description of the phantom size. We heard about this. Now, I've heard that the IEC has standardized this. It's coming out. Software is going to be rolled out. But I'll tell you, if I walk into my institution right at the moment, I'm pretty sure our PEDS protocols are going to be given as dose to 32 centimeter phantom. Okay? So please be careful about that. Again, this is our plea for transparency, but you as physicists need to be aware of this, and whoever's doing the protocols need to know what that number on the scanner refers to, right? Because it's going to be a factor of 2 difference in terms of the magnitude of that number on the scanner. We need some description of patient size. Cynthia uses lateral width. We've been using perimeter in our stuff, but some descriptor of patient size puts this into context. I also really prefer that we have some description of anatomic region. Okay, if all you see is a number, again, we tolerate much higher doses in the head. We need that, okay, than we do in other parts of the body. Okay, sorry, here's a little bit of pitch. Okay, just to put a couple things in context and see what those numbers, where they can lead us. Not now, but hopefully soon. So our group does some simulations where we model this. We do mathematical modeling of the scanner, of the patient, and we simulate scans where we move the X-ray source and we simulate photon interactions. We try to do the whole thing. Photon transport, photoelectric, Compton scatter, absorb dose. We tally dose absorbed at a location. There's a couple details. So we have these models, patient models, where they've outlined all the radiosensitive organs. Okay, so how do I know CTDI isn't patient dose? This is my evidence, okay? You can accept or not, but this is our evidence. Okay, so my question to you was, what really happened to patient dose as a function of patient size? Okay, here's some work that we published a couple years ago in Physics and Medicine Biology. We took all of these patient models from a baby, which I think was on the order of several weeks old. I think it's a 5-year-old up to visible human and some females and adult males. And what you see is generally, for the same techniques, I've normalized everything per MAS, and only thing that's changed here is size. And you see this factor of 2 difference from baby to adult. And you would have thought it would have been bigger, but this is in terms of effective dose. So you have this effect of patient size there. So if I gave them all the same techniques and reported it all to the same phantom, the CTDI would all be the same. Patient dose would be different across that population by a factor of 2. Okay? We can see this here. So this is a general increase in size. Here I did it with weight, but these things behave pretty well. Okay. I'm going to lead to 2 other things, and I think I'm going to finish up with these. This isn't the main point, but I wanted to use this to illustrate something. We did some studies where this is just in press with MedPhys from my student Adam Turner. He presented this at RSNA 2008, so some of you may have seen this before. How does organ dose vary across scanners of different manufacturers? When we tried to do our best to compare, and we did one of each manufacturer. We did a 64-row scanner. We used the same or as comparable as we could get technical factors, and we used this patient right here, whose name is Irene, and we used a head-to-toe scan across. Okay, and then we looked at dose to individual organs. Okay, whoops, and I skipped a slide, didn't I? Okay, nope. So what we found was, and here are different organs. So here's red bone marrow, colon, lung, stomach, et cetera, et cetera. This is all through the body. And what's really interesting is these dots all represent different scanners. Okay? But what we have on the y-axis isn't the organ dose, it's the dose to the organ divided by CTDI. Okay? And so what that showed us was that CTDI isn't organ dose, but it may give us a window into estimating organ dose. Okay? Across scanners. So it really normalizes out the differences between scanners very nicely here. Okay? So we're not there yet, but I want you to notice one thing. This is what I wanted to point out. If CTDI was organ dose, then organ dose divided by CTDI, all those numbers would line up at 1. Okay? Doesn't. Okay? You see here about 1.5, 1.8. Okay? Some greater, some less. Okay. So, what does that mean? So now let's look at, that means, I better talk about the next slide, which is about patient size. Okay, so we did a different thing this time. We didn't do all 4 scanners. We did 1 scanner, but all these patient models again. And this time we looked at organ doses, and I wanted to do this. This is organ dose divided by CTDI volume to the 32 centimeter, specifically to the 32 centimeter, okay? Here's my peds, okay? Here's my adults, okay? It's not all, again, if CTDI was organ dose, all those numbers would line up at 1. They don't, because of different patient size, okay? What does that mean? It means if I report CTDI, I'm going to be accurate for a couple size patients. These are kind of on the larger side. There we go. I may underestimate for a really large patient, and I'm going to overestimate for my smaller patients. And for peds patients, it's a very significant underestimation to the 32 centimeter phantom. Okay, 16 centimeter gets you closer. Okay? Okay. Last point is CTDI vol skin dose. You heard Cynthia talk about this a little earlier. This is from an article that was in Radiographics that she co-authored with, I can't remember the guy's first or last name, but something like Baus. Okay. This is, the question was, is CTDI vol a good representation of the peak dose when you do a perfusion scan with no table movement? In fact, when you're doing no table movement, this is what's happening. You have repeated scans at the same level, okay? As opposed to when you're scanning through anatomy and you have these overlapping and these curves all overlap and create these sort of reinforced waves, and they give you a higher value here, okay? So CTDI vol is an overestimate of skin dose, when there's no table movement. Okay, it's a conservative estimate. Okay, I thought that would be a good thing actually, but okay. So this is just some more text to reflect that it overestimates skin dose. And by the way, yes, the task group 111 dose metric will do a much better job here in this particular value in terms of compensating for the fact that there's no table movement. Okay, but it's still not patient dose. It's still dose to a phantom. So again, sorry, we come back to some simulations, and I'll close with this one, which is we did some simulations of head scans with no table movement, and we looked at, I asked my student, Dijon, and I said, okay, what would the technique be to get to 2 gray at the skin, or 2 gray to the lens of the eye? So we did 2 gray to the lens of the eye, 2 gray to the skin, and we did these different techniques at different locations, scanning right over the eye or far away. And what we found was pretty consistently that the CTDI, again, overpredicts, it overestimates what the actual skin dose is, even in simulation. Not by a factor of 2, like Cynthia said, we found a little less, but it's still a very conservative estimate. So to get 2 gray there, we actually saw 3.4. Actually, that's not too far off from factor of 2. Okay? We saw that for lens of the eye and for skin dose. And the reason this number is so far off is because it's not a very good predictor if you're not scanning right over the lens of the eye, right? Okay. Okay. So, let me summarize. CTDI vol, what is it? It's not patient dose. It is dose to a reference size phantom. That reference might vary from peds to adults. You have to be careful there. There's still some transitions going on. It does underestimate dose to small patients, and it may overestimate the dose to large patients. Okay? It's not skin dose either. It typically overestimates the dose for perfusion scans. And the TG111, the Task Group 111 report, when it comes out, well, the report is out, sorry. When it's finalized and the protocol is finalized, it'll do a much better job of estimating what that dose is. And I'll stop there, okay? Thank you. Okay. I got 2 minutes.
Lots of time for questions. Go ahead.
I have a pedestrian question. Are all hospitals going to have to get accredited, or do we know the answer to that? I know outpatient clinics have to be accredited.
That's what I've heard, outpatient clinics. I have not heard hospitals yet. You want to answer that? Am I right? You're right. Okay, so Teresa says I'm right. That doesn't happen too often. Just make a note of that in the minutes. Okay.
I wanted a little more insight on, you brought up a Task Group 111 report, fairly recent.
Yes.
Could you provide a little more insight? Because if I use it now, I might get penalized, and it's not part of the rules for the current ACR accreditation setup and all of that.
Okay, I'm not sure what I'm supposed to say about that. The task group report is published. It came out in Medical Physics, right? It's on the website. Okay, and it does involve, for those of you that don't know what I'm talking about, I'll be very brief. I think CTDI is measured in a phantom, no table motion with a 100 millimeter pencil chamber. Task Group 111 has a couple different protocols, but one of them is when you have a protocol that does not involve table motion. Again, you do not move the table, but it's done with a smaller chamber. So it's a 24 millimeter length chamber rather than a 100 millimeter. So it doesn't integrate onto the whole length of that dose profile, just trying to capture the peak of that in the specific instance that I'm talking about. There's much more to task group 111 than I'm addressing right here, but I wanted to bring that up. So that may not answer your question. Your question was probably going to be, when is ACR going to adapt it? Next question. There's no specific deadline. We're certainly aware of it. Diana's been on the committee. I was on the committee. We've all been in conversations with Bob Dixon, was the chair of that task group. Certainly, I think there's a few more bugs to work out, like the phantom still needs to be worked out. So there's still a few more things. So it'll be just a little bit.
I'd like to go back to square one to address an issue that I think gets confused a lot of time, and that's table one, and what is an average patient, and how do you come up with those MAS factors when you're using automatic exposure control, and how does that relate to dose in practice, as it may see a lot of very obese patients, practices to see a lot of very small patients, and what they're calling average in your dose limits?
That's a great question. That's an outstanding question, and I don't remember. I think the answer to that is, when I'm standing here with the chair of the committee, so I better ask Teresa. You want to come to the mic? Yeah. Yeah, better. I know what I would say, but you better get the official word. No. Yeah, just hurry up and get to the microphone.
Okay, for the average liver, what I tell people is to look at a nice mid-liver slice. Don't include lung tissue, don't include pelvic bone, because that drives the MA and everything. And literally take an average. So look at several of the facility's patients and look at those nice mid-liver slices and get an average MA from those. And for the head, don't include temporal bone, just a nice, right through the lateral horns is usually good, and look at several of those, although that doesn't really vary, but there are more people using the automatic exposure control on their heads than, even in the past year we've seen an increase. So check on that. And if you need to get an average from there, like I said, a nice right through the lateral horns is usually a good place. PD abdomen, same thing, nice mid-liver cut. And on the high-res chest, right through the middle of the chest, don't get up in the apices because the shoulders are going to throw it off, and make sure that you don't have the dome of the liver on there. And if you just take, 5 to 10 of those, average them out, and then put that on table one. But exactly. Be consistent.
So that's a much, much better answer than you would have gotten from me. Thank you, Teresa. And let me point out one thing, because the questioner asked a great point. Everybody gets small patients, everybody gets big patients, okay? We understand that. And so the fact that you bump your techniques up or take them down for the appropriate size, that's not what we're talking about. We're asking about the average techniques for this average patient, with this mythical average. I wouldn't mind if we spend another couple seconds on what do you do with tube current modulation. For those of us that have a scanner that reports an effective MAS, that seems pretty straightforward. For those of you that have a scanner that reports something like standard deviation or noise index, I don't have a specific guidance there. Do you have some wisdom to impart there? Or? No. Okay, sorry about that then.
Oh. Well, I do. You basically do the same thing. You look at the average patient, look at the MA, and that average patient across a bunch of patients. It does show you the average MA for a rotation, not necessarily for an image. It will be the same number for as consecutive images, all collected in the same rotation. But it will give you on that image what the average MA was for that particular rotation. So it works the same way.
Okay, and one other, so we've talked about this before too, is that some scanners, at the end of it, you'll get this little dose report. You've seen that? And sometimes in our scanners, they report the average effective MES for the whole scan. Okay? Other scanners don't. So it's a little stickier. What she's talking about is a little more painful, but it can be, the information is there. It's just painful to extract.
Sorry, Tom. Got to move on. Okay. Got to be fair.